My name is Dr. Langley. I'm one of the consultants based at the Royal Brompton Hospital, and over the next 40 to 50 minutes we'll try and cover some of the aspects of managing complicated pneumonia. Feel free to put questions in the chat feature. I will try my best to navigate the technology, or I can look at the end and we can perhaps go through them. If people can mute their microphones and switch off their audio, mute their microphones and turn off their video, it makes things a little bit smoother and the technology works a little bit better. Okay, so the first thing that we're going to just talk about very briefly is, before we go into the complications of pneumonia, is a little bit about community-acquired pneumonia in general. And I think much of the issues that we find with community-acquired pneumonia are dealt with by primary care and A&E and secondary care in district general hospitals. And although quotes of 60 to 80% of potential upper respiratory tract infections are maybe caused by viruses, it's impossible to distinguish on clinical features between a viral and a bacterial pneumonia. It's very difficult. So if someone suspects a community-acquired pneumonia, generally antibiotics are required. And the PaeCH study in 2007 showed very clearly that oral antibiotics are usually enough, and that the only requirement for intravenous antibiotics should be as if the patient is unable to tolerate oral fluids, they're vomiting, they look like they're septic, or you fear that there's a complicated pneumonia. And oral amoxicillin, clarithromycin, azithromycin, chlomoxiclav are all suitable antibiotics that should manage community-acquired pneumonia. There are various other antibiotics that can be used, but generally, as we say, amoxicillin is first line unless there's an allergy, and if there's no response, then you can switch to macrolide. Azithromycin is a good antibiotic because it doesn't taste too bad. You only need to take it once a day, and you use it for 3 days. Unlike its macrolide friend, clarithromycin, which tastes absolutely disgusting, you need to take it twice a day, and it's for a longer course. And in general, children will not tolerate it. So we have to be realistic, we need to be pragmatic and understand that we're dealing with children and they will not tolerate gritty, disgusting tasting medicines. So it's sometimes easier to use, even if it costs a little bit more financially, it's sometimes better to give the antibiotic that you know they'll at least take, rather than think that they'll take it and actually they're not doing it properly. What we won't have time to discuss today is someone who has pneumonia with an underlying diagnosis, such as chronic suppurative lung disease, CF, PCD, or bronchiectasis, whether or not they have a primary or a secondary immunodeficiency, and that also covers quite a wide range of opportunistic pathogens, and we don't have time to look at ventilator-associated pneumonia. So I guess the first thing really is to think about how we would diagnose a complicated pneumonia and how we diagnose it as being severe. And some of the criteria that you can see on the screen just now highlights why we think it's worse than just simple, if you like, community-acquired pneumonia. And you can see that all the physiological parameters that's provided there, SATs less than 92%, respiratory rate greater than 50, respiratory distress, high fever, CAT prefill time delayed, and signs of potential shock or dehydration, you could basically apply that to any major infection in children. So if you took out the saturations, a child may present like that with pneumonia, or with meningitis or sepsis or another serious infection. So you can see that the criteria isn't necessarily specific to pneumonia. What does make it more suggestive are the low saturations. Again, in infants, it's quite difficult because, as any paediatrician knows, there's a large number of children will present with viral upper respiratory tract infections. So a bronchiolitic child may present with a respiratory rate greater than 70 with marked subcostal recessions, apneas and poor feeding. So again, it doesn't tell us exactly what's going on, but it gives us an idea that the child is clearly more unwell than one would expect from a simple pneumonia, and I use that in inverted commas. So why it gets so bad, there's probably a number of factors. And I think you always have to remember that there's an interplay between host and organism. And we don't fully understand why some children will be more prone to getting a particular type of bacteria. Indeed, we don't know why some people who get RSV, for example, become so unwell they require intubation, while the vast majority of children have a bit of a runny nose and a cough for a few days. So there are always host factors, but I don't think we've got time necessarily to think about that just now. But we can look at the organisms that are out there. And certainly when you look at the positive cultures that you get, either from pleural fluid or from blood, these are the usual suspects that seem to cause quite a nasty infection. So invasive pneumococci, and some of these are new serotypes that are not covered by the valent vaccine. PVL, Staph aureus, Group A strep, and adenovirus can all cause very nasty, complicated infections. I have seen other organisms, so I've seen Mycoplasma cause complicated pneumonias, and there are others, but that would be your top few. Also, if the pneumonia affects both sides, clearly, if you've got marked infection of both lungs, that will have a larger decompensation than if only one lung was involved. And also, you can classify it if it's complicated by severity, if the child requires intensive care. Because as I've said, the vast majority of community-acquired pneumonias are managed by general practitioners with some oral antibiotics. So if the child requires non-invasive or mechanical ventilatory support, then clearly they're not following the usual path. In general, our experience, or my experience of complicated pneumonia, is generally single organ failure, but clearly you can have a systemic inflammatory response, you can have DIC, etc., related to the sepsis. But in general, even a complicated pneumonia is generally just a single organ failure. But it's very serious. So we do know that if you look at the mortality figures, you can see that if you're less than 1 year old and you have a severe pneumonia, it does carry quite a high mortality. So it's not something that we can ignore, and it's something that we have to be mindful of. In terms of non-pulmonary complications, as I've said, septicemia with widespread dissemination of organisms is a possibility. You can get an ARDS type picture where the child becomes difficult to ventilate. You can have fluid balance issues, and any child that presents with a low sodium and a high CRP, you have to think about sepsis as being the reason. Hemolytic uremic syndrome. So typically, hemolytic uremic syndrome is thought to be attributed mainly to enteric organisms such as E. coli 0157. However, the second most common cause of hemolytic uremic syndrome in the UK is pneumococcus. So it's important to look at the blood parameters and think about hemolytic uremic syndrome if your child is getting sicker. And the other thing is you can obviously have an increased blood marker such as the thrombocytosis. So if you have a child who you think has got a pneumonia and you fear it's severe and they're not getting better, what do you do? So I think there's a number of questions that you need to think about. One is, are they still septic? So have you got the wrong antibiotic? Now, generally in this country, pneumococci thankfully remain fairly beta-lactam sensitive, but if you're treating a patient who comes from some areas in Europe or wider afield, pneumococcal resistance rates can be as high as 70, 75%. So you have to bear that in mind, that if the child is not getting better despite adequate, or what you think to be adequate antibiotic coverage, then you might need to think about altering the antibiotic. The other thing that you've got to remember is that the way that the beta-lactam antibiotics work is that they inhibit cell wall division, and they can cause rapid lysis of of bacteria. So if you've got an organism which something like PVL staph or an invasive pneumococci that releases toxins which are cytotoxic, then if you cause a massive cell lysis of the bacterial load, then you will flood the system with endotoxins. So on your gram negatives, it would be LPS, and if you look at gram positives, it would be components of the gram positive cell wall, such as lipoproteoic acid. And these toxins cause a massive cytokine storm, or have the potential to do so. So sometimes what you might do is give antibiotics and find the patient gets a bit worse, and that's because you've flooded the system with toxin. So there are a number of mechanisms which might make the child look worse. Things that you can do quickly is to add broader cover or different antibiotics. So aminoglycosides are very good for gram-negative cover, and they're bactericidal, so they're very good at inhibiting protein synthesis. And that's important to think about, because if you've got bacterial factories making lots of toxin, by adding an antibiotic that inhibits protein synthesis, it makes sense that you're actually shutting these factories down as well as killing the organisms. Likewise, clindamycin is a fantastic antibiotic. It's got great tissue penetration, and although at some concentrations it's felt to be bacteriostatic, it does a similar job to the aminoglycosides in that it can inhibit protein synthesis. And there's also some suggestion that it's almost like an antitoxin. So the charge on the molecule helps to limit the access of toxins to the cell receptors. So clindamycin is a great antibiotic to use. The other thing is, are you thinking about the right organisms? So as we say, there's a who's who of the most common organisms that cause pneumonia in children, but if they're not getting better, they've come from somewhere else in the world, then you always have to think about something like tuberculosis or a slightly more hardy organism that wouldn't be covered by the antibiotics we typically use. The other thing you've got to think about is, why is the child so unwell with something that's generally not that much of a problem? So you need to think about immunodeficiency in that child. Do they have underlying bronchiectasis? Do they have a thoracic malformation, which may explain why they become so unwell and out of character for that condition? Or what's happened is that your actual primary focus in the lung has become complicated. So the complications, there was a BTS audit in 2010, 2011, looking at about almost 2,500 cases. 50% were less than 3, and the severity markers are shown. And of pediatric pneumonias, what you found, there was complications in about 7%. And the most common was an empyema and then abscess. So the acute complications are fluid in the wrong place, if you like, either that, be it in an abscess or as a empyema parapneumonic effusion. There's an issue with air in the wrong place, so either a pneumatocoele or a necrotizing pneumonia, or there's collapse of a lobe, which has made things worse. So if we think about lung abscess to begin with, essentially what it means is you've got fluid, in this case pus, inside a cavity which is bigger than 2 centimetres, that has a well-defined wall, and it's within the lung parenchyma. And there's X-ray appearance, which is usually typical, where you see an air fluid level. The vast majority of abscesses are poorly oxygenated, so one must think that anaerobic organisms would thrive, and that seems to be the case, in that 70 to 90% present with an anaerobe, or at least have anaerobes involved. And that might affect your antibiotic choice also. So why are anaerobes there? Is the child aspirating? Is there another underlying issue as to why that would be the site? Why they would be the cause? You can have multiple or single lung abscesses, and they can vary in size. And the vast majority you'll be able to see on an X-ray, but if there's an indeterminate diagnosis, you may want to do a CT scan. The key to managing lung abscesses is the time you give antibiotics for. So this isn't a 48 hours until they look a bit better and then switch to oral. This is this is the long game, so 2 to 3 weeks of intravenous antibiotics, which carries its own difficulties in children because you need to think about access early if you suspect an abscess so that you're minimising the trauma on the child. And then after we've given a substantial course of IV antibiotics, we then have a follow-up of 4 to 6 weeks of oral antibiotics, which again you have to think about closely because you need to choose a suitable antibiotic that will cover anaerobes. And in the vast majority of cases, if you follow the guidelines and give a prolonged course of antibiotics, we'll be optimistic 90% of the cases will resolve with no problem. In general, you shouldn't mess around with an abscess. So if you think it's an abscess, you can treat with antibiotics and avoid putting needles in things unless the patient is compromised, so there's a mediastinal shift, or they're ventilated and you're struggling. The worst thing you can do is go poking around in something that would, in 90% of the time, get better if you just treat it with antibiotics. And then what you then have to think about is, was there an underlying congenital thoracic malformation? Was there a cavity created by a fungus, etc., etc.? So there may be underlying issues in the child. So they will require follow-up, as one would expect, but that's for a later day. So on this chest radiograph, you can see on the right side of the thorax, you can see this child had a CCAM, so we had no problems from the CCAM, which was diagnosed when they were a child, an infant, and it later became a focus for infection. So we don't have time to discuss whether or not you should remove all CCAMs to prevent this from happening. But certainly, if you do have a CCAM, there is always the potential that becomes infected, and it should form at least part of the counselling when you're discussing this with families. So if you look on the upper left of your screen, you'll see an abscess in the upper zone on the right, and the CT image showing the thick-walled cavity, which is greater than 2 centimetres. And after a prolonged course of treatment, you can see an improvement in the bottom radiograph, showing some outline, but a much improved fluid air level. Again, just some further imaging. So the most common complication is an empyema or a parapneumonic effusion. And this is essentially fluid, pus or Sears fluid between the lung and the chest wall, i.e. within the pleural cavity. A chest x-ray is good at identifying this, and if there's any doubt, ultrasound is key to find out what's actually going on. We don't routinely CT children to diagnose an empyema, but I have seen it done at different centres, but it should not form part of your routine investigations. If you look at how an empyema is managed, it's slightly different to an abscess in terms of the duration, and it follows a similar pattern to how you manage anyone with a general septic episode. So you would give antibiotics until they were no longer septic, and usually 24 hours after the drain out, and you would complete 2 weeks of antibiotics at home. Now, what I would say is that the until no longer septic point in that sentence is difficult to quantify. So some children respond very well and very quickly to antibiotics. Some grumble along for a very long time. So there's a slide later on that basically says about patience, and I think that's important to remember, is that with all of these conditions, it's difficult to be specific to parents about how long it will take to get better. So it's better to be slightly vague and say, essentially, it will take as long as it takes. It's really important to remember that it's quite painful for children to have inflammation of the pleura. So you need to think about adequate analgesia. Equally so, if you're going to put a chest strain in the side of a child, you need to make sure that they've got regular analgesics written up, including morphine, because it can be very sore. And actually, a lot of the important convalescence of a child with a complicated pneumonia is getting them up and moving and breathing normally. So if they're in pain, you're probably going to prolong their their illness to some extent. In children, we would always recommend that a chest drain is put in under general anaesthetic, and only if the effusion looks more than 2 centimetres. And the ultrasound scan is very good at telling you if there's any sort of fibrin septation of the empyema, and that's when you would think about something like intrapleural urokinase. So this is a series of images that we don't necessarily need to talk through. So some gram-positive organisms in the middle, and essentially you've got a variety of x-rays which shows what an empyema or a pleural fluid looks like, and some ultrasound images of the measurement within the pleural space. And this really just shows the procedure. So all of our chest drains here are radiologically inserted. Other centres I've worked in, some surgeons might get involved, and we'll come on to just the differences of management. But essentially, it's fairly straightforward. You put the drain in and you remove fluid. Be very careful you don't remove all the fluid in one go. It's very important that you limit the fluid. It's caused massive fluid shifts, so fluid off. And you should follow a local guideline on chest drain insertion and management of chest drains. So one of the great debates in paediatric respiratory medicine is whether or not you should manage an empyema with a medical approach, if you like, so it's a chest drain and some antibiotics, or whether you should go down the surgical route. And within the surgical route, you've got the VATS and the thoracotomy debate. Essentially, the evidence isn't brilliant. There is some school of thought that if you have a surgical approach, such as a VATS, you may shorten the length of time to get better. But actually, both groups do very well. And I think the key thing is actually be good at what you do. So agree a local policy and stick to it. If you've got cardiothoracic surgeons that are very keen to do this and they're very good at it, then let them do it. Equally so, if you're struggling in a centre where you don't have access to cardiothoracic surgeons, then who are willing to do this, then a chest drain and antibiotics is very good. And the bottom line is that most children with an empyema get better anyway. Somebody has their mic on, if somebody wouldn't mind switching it off. I don't know who it is. I don't know if I can do that. Sorry. So this is our trusty surgeon up on the left, scrubbing in, and that's what it looks like when you put the scope in. So you have marked debris and pus, and what they do is they go in and they clean all that up and often leave a drain in. So my experience has been working in centres where they've done both. So here we do chest drains in Glasgow. It's a VATS procedure that's done and the patients are looked after by the surgeons. And to be honest, I've not noticed any vast difference. And if you look at the evidence, that would support my anecdotal experience. And again, why is there such a variable practice? Well, most of the evidence is sort of grade D and level 3 evidence. So we've not got huge numbers of studies around. This was from 2005. There's a few later ones, but there's not huge amounts of evidence. So the next thing to think about in terms of a complicated pneumonia is it's not always an infection. So these two, one at the CT on the right and the chest radiograph on the left of your screen, show that it can look like fluid, but actually you need to have a proper understanding of what you're doing. So what you don't want to do without ultrasound is to be pushing chest drains into children's chests if you don't actually know what's there. So remember, most children with empyema get better anyway. So this is not a rushed decision to be made. You shouldn't be putting chest drains in out of hours if the child is stable and looks okay. And actually having a cautious approach is much safer for the child. Clearly, if the child looks critically unwell and somebody feels they need a drain because they're worried about air leaks or something, that's a completely different scenario. But if you think this is somebody who's got complicated pneumonia with an empyema, you need to get the evidence before you put needles in, and that would be catastrophic if you didn't do that, particularly in a child who on the left has a pericardial effusion, and also if the child's got a cardiomyopathy. So your radiologist can really help you in your decision making and make it as safe as possible for the child. The key question that we always ask, and we always get our registrars to ask, is what is the white cell count in CRP? So if the child presents with low-grade fever and has been unwell for a week or so and has a CRP which is in single digits and a white cell count which is normal, that should ring alarm bells that what you're dealing with is not a complicated pneumonia. And it's very important that those parameters are thought about, and if in doubt, discuss with someone, because the worry is that one of these conditions are missed or are treated with antibiotics without suitable thought or further imaging. So it's very, very important that you think about the inflammatory response, because these children by definition should look pretty sick, and they should have blood markers that reflect that. And this is a series of films for a child that presented with bilateral empyemas but actually had an underlying diagnosis of Burkitt's lymphoma. So these things are quite rare, but they do happen, and every year there'll be children that present to relatively small DGHs with complicated lung pathologies that are not infection. The other thing to think about, of course, is what it is that you're taking off. On the right side, you can see this was a chylothorax, so this wasn't serous fluid or pus, it was a lymphatic leak. So a pneumatocoele is essentially air inside a thin wall cavity, again within the lung parenchyma, but you should not see an air fluid level. So you should be able to differentiate between a pneumatocoele and an abscess by this radiological appearance. Pneumatocoeles are normally associated with Staph aureus and Streptococcus, so are two old friends that cause most of the problems. They can become very large. They can lead to pneumothorax. In general, our advice is leave them alone. Again, intervening can make things worse. They can take many months to resolve. So this idea that you repeat an X-ray after 6 weeks is probably a bit too soon, but you probably do need to think about doing repeat imaging at some time. So around about 2 months, most will have resolved, maybe not completely, and some will take slightly longer. So again, here's a series of images of pneumatocoeles, and you can see the timeline from the 9th of December. And by the time we get to the 25th of May, the radiograph looks relatively normal. This was caused by a PVL Staph aureus. I think the key thing that I haven't mentioned is that we often don't get an organism, so don't be expected if you don't actually know what the organism is. And again, this is another series of images from the 4th of November round until June, and you can see the improvement in the chest radiograph over time. So another complication of a pneumonia is a necrotizing pneumonia, and these patients often don't present initially with sepsis, so they may have a pneumonia that's been treated and then they get worse, and they can look very, very unwell. And essentially, it's thought that part of the pathology is due to blood clots, essentially in the intrapulmonary vessels, and you lead to ischemic damage in the lung parenchyma. You get necrosis of the downstream tissue, and you get cavity formation. One of the complications would be a bronchopleural fistula. You get an air leak, and you can have a pneumo or a pneumothorax. And this takes a long time to get better. There's a few organisms that seem to like to do this, so pneumococcus serotype 3, Staph aureus, and Klebsiella. And you can see the images on the screen now. So you on the top screen, you've got a left-sided fluid level and an X-ray of a fairly unhealthy looking lung, and then 6 months later it looks okay. So to manage the necrotizing pneumonia, again, you need to have prolonged course of antibiotics. This is not something that's going to get better in 24, 48 hours. And the child may spike for a long time because the inflammatory process is quite significant. So you're looking at a time frame similar to managing an abscess. I think the key take-home message is keep surgeons away. So some of the worst sort of interventional issues I've seen is when someone has been a bit overzealous with a scalpel on a child who has a necrotizing pneumonia, because essentially it's in a state of flux, and if you go in and disturb the necrotized tissue, you will make further air leaks, and you'll never be able to get to the end of that. So you'll just keep cutting and cutting and cutting, and you won't be able to get to the source of the problem, and you'll just make the situation worse. It usually needs a drain, and again, that drain can be in there for many weeks, because if you think about the exposure of small airways through the necrotic areas of tissue, you'll have air leaks. So you need to think about a drain, because to manage the complication of bronchopulmonary fistula, and the drain may be slightly different from the ones that we'd use for liquids. Please try and, in fact, it should be a kind of do not do fibrinolytics unless you've really thought about what you're doing, because if you think about the process being completely different from an empyema, you've got necrotic tissue that is being held together by fibrin strands as part of the healing process. So if you tip urokinase into the drain to try and improve healing, all you actually do is break down the healing lung, and you will make the chances of complication higher. So you might increase the risk of bronchopulmonary fistula. So the key is be very patient and try and explain to parents at the very beginning of this, once you've diagnosed the necrotizing pneumonia, that this isn't going to take a long time to get better. And I think you can be reassuring to them in that the vast majority of children who have necrotizing pneumonia will have a normal radiological appearance and will have normal lung function. So unlike an adult who suffers from necrotizing pneumonia, which can be catastrophic, in children, the ability of the lung to regenerate its structures is phenomenal. So it has to be said that the vast majority of children get better, and it just needs patience. So the child will be sick for a while and then gradually get better over time. And it's important that everyone's on board with that. And part of the communication skill that's required is to say to parents, this is going to take time, and be honest and open up front with them. So these are a series of radiographs ranging from the 23rd of May up until the 19th of June. And you can see that on the 23rd, you wouldn't necessarily say there's obvious evidence of a necrotizing pneumonia. And as you work through the films, you can see that you've got homogeneity within areas of black and white, suggesting there might be necrosis. And as you work down, you can see the large air leak in June, and then by the time we get to the end of June, things are looking better. So there's a well-recognised pattern of improvement, and you can see this across all the children that we manage with necrotizing pneumonias. And again, a similar series of images showing improvement. But again, it's not instantaneous. It will take time to get better. The other thing that can happen in terms of pneumonia is collapse, so atelectasis, and this can happen in an acute sense. So often people would rush to physiotherapy, but actually in pneumonia, that's not necessarily going to get you better quicker. But if you have an acute collapse of a lobe, then physiotherapy and bronchoscopy are sometimes required if you think there's a big mucus plug. And if there's lots and lots of mucus around, and this is not the first time this has happened in a child, you need to start thinking about underlying pathologies. The other key thing to think about with acute atelectasis is foreign body, and I think this is one area that we probably don't do that well across the country in terms of thinking about foreign bodies. But if there's any suggestion that a child may have aspirated a foreign body, then it needs to be taken seriously. And it needs a discussion with your local ENT team about, do you think this child requires a scope? It's not really the job of the respiratory doctor. It's an ENT referral to ask what they think the likelihood is. And if there's any, if in doubt, you should have a look, because what you don't want to miss is organic material within the airway, because that can lead to quite nasty issues for the child later on. So if you think about it, you need to take it seriously, and you need to discuss with colleagues who can remove those foreign bodies from the airway. So it should be thought about. The other thing that can cause atelectasis is airway compression. So if you think about it, if you're blowing up a balloon and you squeeze the end, it will collapse. And what would cause that in an airway? Well, there's various areas of vasculature, etc., that can cause airway compression. But in terms of an acute situation, you have to start thinking about, is there lymph nodes? Is there potential TB that's caused the lymph nodes, that's caused the collapse? So the other thing to think about is, with airway compression, is there something else in the airway? So we'll come on to that in a second. So this is just a series of images where initially started off as an empyema, and then there was some atelectasis at the end of the right upper lobe. And if you're unsure of the causation, then it's very important that you do further imaging to try and delineate the actual underlying pathology. And that's true if you choose to do a follow-up X-ray. So all these children should have a follow-up X-ray. Community-acquired pneumonias that are managed purely by oral antibiotics should not. But if the child has got a complicated pneumonia, then they should have a follow-up X-ray. Or if the child has several episodes of seemingly normal community-acquired pneumonia that's responded to antibiotics, but they've had a few episodes of it, then again, that's not typical. So again, if the chest X-ray doesn't get better, so it looks like that collapse is a chronic process, then you need to think more about the underlying airway and lung structures to try and delineate what's actually going on. So again, you can have chronic mucus plugging, again, foreign bodies. And please don't forget that you can have airway tumours and polyps in children. It's pretty rare, but you need to think about these things. Likewise, so that would explain if the lumen is blocked. If the lumen is compressed, again, look at imaging, look at the lymph nodes, think about tumours, think about the vasculature that surrounds that airway. And again, if the lumen is narrowed, then do they have an underlying Malasic process which is causing narrowing? Or do they have a right middle lobe abnormality which causes a slit bronchus and then downstream collapse of the right middle lobe? And I think it's very important to also think about if there's any previous imaging that's been done. And again, you can look at things like congenital thoracic malformations that may have been missed from early childhood. And again, think about tumours. So these are not decisions that generally are made by individuals, they're made by an MDT. It's very important that that one thinks of possible complicating factors and then discuss with other clinicians, but also with the radiology colleagues to try and work out exactly what's going on. Because as I say, the vast majority of children with even with abscesses should have a normal, or at least a normalizing X-ray. It should not remain abnormal. And this is what, when you put the bronchoscope down, this is sometimes things that you see. So on the top left, you can see some sputum, which is blocked off the airway. And actually, with good aspiration of that, you can normally open up the downstream segments. Equally so, foreign bodies are important to think about. If you see something that you're not sure what it is, it's probably better, again, not to go poking around, because if you look at the TB plaque, for example, or if you look at the tumour in the bottom, sometimes it's difficult to know exactly what that is. So that spindle cell tumour could easily be a piece of peanut which has become kind of absorbed into the wall of the airway. And you can look at the erythema there, so it's vascularized. If you go and start trying to remove that without knowing what it is, you can cause significant blood issues, and if you've got a flexible scope, there's not much you can do to fix it. So if you're not sure what you're looking at, the safest thing to do for the child is to stop, take adequate images, and discuss it with radiology, if you need further imaging, to discuss with ENT to see if they have experience of what they think it might be. And then if there's any doubt, take the scope out and go back down later to have a look. So if there's no obvious history of foreign body and you see things that you're not sure what they are, try not to remove them, because you could make a bad situation even worse in the acute sense. So just to round up, most pneumonia in the UK is easily treated. We've got access to the general practitioners who are very good at picking this up on clinical grounds, and we have treatments that are available, and the vast majority of children should do well. However, it can be very severe, and children do die of it. So you saw the mortality figures at the beginning, particularly under ones. 1 in 5 can have a fatal outcome. So you need to think about it, and you need to treat it seriously. The most common complication is empyema, and we've discussed how chest drain insertion and fibrinolytics is often the best way to do that. But if your centre uses VATS or surgical intervention, then equally so, that has good, if not better outcomes. In terms of necrotizing pneumonia, we are recognising it more often. Now, whether or not that's to do with different strains of organisms coming to the fore when we've vaccinated against others, it's always important to remember that although we can increase the serotypes within the vaccines, there will always be other pneumococci out there that are wanting to get invited to the party. So remember, there's other bugs. The other thing is that if you clear the airway of commensal pneumococci, which used to be around, you're going to open that up to potentially other more invasive organisms such as croup A strep. The vast majority of pneumatocoeles will resolve. And I think the key is that, unlike our adult colleagues who are very conscious about antibiotic use, I think paediatrics generally we use antibiotics more readily, but in this case we probably do genuinely need to use more antibiotics and for longer. And I think the key is to try, unless they're doing VATS, try to keep surgeons away, because as I say, you don't want to go into areas that would generally get better anyway with good medical care. Okay, so I'll see if there's any questions in the chat. Okay, if there's no questions, then we can end there. Thanks very much.
Thanks very much.
Thank you.